Dear participants, dear Chairman, thank you very much for introducing me. These are my disclaimers. The objective of this presentation today is to guide you through the newly gained evidence of brivaracetam adjunctive treatment under real-world clinical routine conditions. Just a short refreshment. Brivaracetam is a selective high-affinity ligand for synaptic vesicle protein 2A that rapidly penetrates the blood-brain barrier. Brivaracetam is indicated for the treatment of partial onset seizures in patients 4 years of age and older. The global development program of brivaracetam is continuing. And as you can see on this slide, there are several trials running in the Asian Pacific region, as well as worldwide in pediatric populations. Efficacy of brivaracetam was shown in 3 phase 3 trials involving a total of 1,558 patients, aged 16 years and above. Based on the pooled data of these 3 trials, the frequency of the seizures was at least halved in 34 to 40% of the patients, adding brivaracetam at doses between 50 mg and 200 mg per day, compared to the placebo with 20%. Most commonly reported adverse events during the treatment were somnolence and dizziness. Efficacy in pediatric population 4 to less than 16 years of age have been established using extrapolation methods. And in addition to that, safety was evaluated in 2 open-label trials, and reported data were generally similar to those seen in adult patients. As for all medicines, data on the use of brivaracetam in clinical routine are continuously monitored. And non-interventional observational studies are one of the possible instruments for monitoring of effectiveness, safety, and tolerability, as well as patient-reported outcomes, confirming in this way the results of pivotal trials. UCB Pharma has also initiated a series of non-interventional studies with brivaracetam. And today we are happy to share with you some recent and already partially published real-world evidence of 2 of those studies conducted across European countries. EPI-0077 study, the BASE study, the prospective non-interventional study, and EPI-0104 study, the retrospective chart review in Germany. The first study I'm going to present, the EPI-0104 study, was a retrospective chart review across 20 German specialized epilepsy centers in patients who substituted with brivaracetam at least 1 anti-epileptic drug, according to the real-world conditions. And the objective of the study was to focus on assessment of the success of this substitution. In addition, effectiveness was analyzed by speed of withdrawal of the substituted anti-epileptic drug. And we identified 3 subgroups. Fast subgroup for 24-hour substitution, the medium subgroup for up to 1 month substitution, and the slow subgroup for up to 6 month substitution. Also, safety of brivaracetam was explored, focusing on the patients switching specifically from levetiracetam to brivaracetam treatment and patients who reported behavioral adverse events. In total, 506 patients were enrolled in the study, and those patients were treated with brivaracetam between February and August 2016. Mean age of the population was 42 years, and the gender splitting was equal. Patients were highly refractory with a median of 7 lifetime IEDs and median number of 3.8 seizures per 28 days at the baseline, living with epilepsy for mean number of 25 years. Also, 65% of the population were patients who already experienced levetiracetam treatment before brivaracetam introduction. Effectiveness results. Most common reasons reported within the study for starting brivaracetam were lack of efficacy of the current treatment for 66% of the patients and behavioral side effects of the current treatment for 20% of the population. 85% of the patients substituted at least one antiepileptic drug with brivaracetam, and in the half of the patients it was levetiracetam, and for 46% of the cases it was done within 24 hours. Median dose of brivaracetam was 100 mg per day at the start and followed by 200 mg per day after 6 months. 47% of the patients who substituted with brivaracetam at least one antiepileptic drug remained on brivaracetam treatment after 6 months. In the subgroups, proportions were between 50% in the fast subgroup by antiepileptic drug withdrawal and 58% in the slow subgroup. Irrespective of the substitution completed or not, Kaplan-Meier estimated 6 months retention was 71%. 1/3 of the patients reported 50% response, and for 13% of the patients, seizure freedom was reported after 6 months. In the slow withdrawal subgroup, 50% response and seizure freedom rates were higher, with 48% and 17% of seizure freedom after 6 months. In general, the observed 6-month safety data within the study were in line with the known safety profile of brivaracetam, and we didn't reveal any new or unexpected safety signals or signs. The reported incidence rates of adverse events in the first 3 months after brivaracetam start with 28% were similar to the reported incidence rates for adverse events at the historical baseline with 31%. And only for few patients, adverse events were reported in the last 3 months after brivaracetam start in the months 3 to month 6. For behavioral adverse events, the incidence rate reported within the first 3 months after brivaracetam start with 7% was lower comparing to the 13% for behavioral adverse events reported at the historical baseline. And only few patients reported behavioral adverse events in the last 3 months after brivaracetam introduction, months 3 to month 6. Aggression and irritability were those most commonly reported behavioral adverse events during the course of the study. In the patient subgroup who withdrew levetiracetam, the incidence rate for behavioral adverse events following brivaracetam initiation was lower with 8%, comparing to the 19% for behavioral adverse events reported at the historical baseline. The second study we are going to discuss, the EPI-0077 BASE study, was a prospective non-interventional study. And this study was designed to observe 12 months effectiveness and tolerability of adjunctive brivaracetam treatment according to the real-world conditions in several European countries, also with specific focus on health-related quality of life in patients. The snapshot of this interim analysis we are discussing here was done in April 2018, and the focus of this interim analysis was on 3 and 6 months outcomes. We included in the interim analysis 261 patients coming from UK, Germany, Denmark, Ireland, and Netherlands. The mean age of the population was 42 years, and half of the patients were female. The patients were highly refractory, with median number of 5 seizures per 28 days, mean number of 8 lifetime IDs, and living with epilepsy for mean number of 23 years. 80% of the patients had at least 2 concomitant antiepileptic drugs at the study entry before starting brivaracetam, and more than half of the patients were levetiracetam exposed patients. Effectiveness results. The vast majority of the patients introduced brivaracetam because of the lack of efficacy of previous treatment, with 88%. Median model dose of brivaracetam during the course of the study was 100 mg per day. 62% of the patients remained on brivaracetam treatment after 6 months. For half of the patients with 54%, 50% response was reported. And in 8% of the cases, seizure freedom was reported. In the subgroups analyzed by the number of lifetime antiepileptic drugs, numerically better effectiveness outcomes were reported in the subgroups with 0 to 3 and 4 to 6 lifetime antiepileptic drugs, compared to the subgroups with at least 7 lifetime IDs. The proportions for 50% response were between 67 and 70%, and the proportions for the seizure freedom were between 12 and 19% after 6 months. On this slide, you see the summary of the changes in health-related quality of life outcomes and cognitive performance between the baseline and 6 months after brivaracetam treatment. Overall, 44% of the patients reported a clinically meaningful improvement, and 15% of the patients reported a worsening, measured by patient-weighted quality of life in Epilepsy Inventory Form 31. In some domains, as cognitive functioning, medication effects, and social functioning, more than half the patients reported an improvement. Both physicians and patients reported similar results for global impression of change in symptom severity in connection to the treatment effectiveness. 67, 66, and 57% improvement respectively. No significant changes were reported in cognitive performance for 64% of the patients as measured by the EpiCheck instrument. And 24% of the patients reported improvement, and 12% of the patients had a worsening in cognitive performance measured by the EpiCheck tool. The observed safety data within the EPI-0077 study were also in line with the known safety profile of brivaracetam. Half of the patients reported at least one adverse event. 13% were serious and 35% were drug-related. Most frequently reported drug-related adverse events were drug ineffective, seizures, and fatigue. 15% of the patients reported at least one psychiatric adverse event, and aggression, depressed mood, and irritability were most commonly reported psychiatric adverse events, all below 3%. And now I would like to conclude. Results of these two observational non-interventional study, EPI-0077 prospective non-interventional study in Europe, and final results of the EPI-0104 retrospective chart review in Germany, showed good effectiveness and tolerability of adjunctive treatment with brivaracetam in difficult-to-treat populations across European clinical practice, either adding brivaracetam to the existing antiepileptic treatment or substituting with brivaracetam another antiepileptic drug. Numerically better effectiveness outcomes were observed in patients with 0 to 3 or 4 to 6 lifetime antiepileptic drugs, comparing to those patients treated with at least 7 lifetime antiepileptics. Brivaracetam introduction was associated with improved health-related quality of life without impacting cognitive performance. Observed treatment-emergent adverse events were consistent with the known brivaracetam safety profile, and most patients had treatment-emergent adverse events of mild or moderate intensity. And last but not least, following brivaracetam initiation, a reduction in adverse events was observed, as well as lower incidences in behavioral adverse events in patients who stopped previously brivaracetam treatment was shown. Thank you very much for your time and attention, and we are open for questions.
Thank you very much, Dr. Leunikava. We have a number of questions that have come in the last few minutes. I'll start with one by Jackie French and a related one. What happens when brivaracetam was given in combination with levetiracetam? And similarly, can you comment on other combinations or subset analysis with other anti-seizure medicines?
Thank you very much. Can you hear me well? Maybe I can start with the first part of the question, combination brivaracetam and levetiracetam. As I presented those two studies, so the patients on brivaracetam treatment, we observed in those two studies were coming from 2016-2017, so right after or closely to the marketing authorization. So therefore, the experience on the treatment with levetiracetam is quite limited. And those few patients we have in the EP77, I think the post-hoc analyses are still outstanding, according to my knowledge. And as soon as the data are analyzed and available, we will disclose them. But maybe my colleague Cedric can say more to that, also on the experience in the clinical trials.
Yes, absolutely. And so what we've seen in the first two RTCs is that we had up to 20% of the patients that could have concomitant levetiracetam and brivaracetam. And what we saw in the randomized control setting is that there was no added benefit when adding brivaracetam to levetiracetam. So I think it's very important to know. What we still don't know completely is whether that is true in clinical practice and in a longer use than 12 weeks.
Thank you very much. So another question coming from David Labiner is, can you be more specific or comment on the withdrawal differences between slow and fast?
Yes, so they're very good questions. So there were different, since the amount or sample size of the patients in the EPI 104 study was quite small for the observational resource with 500 patients, we didn't see any treatment pattern and specific, for specific combinations. And in that case, we decided to build some subgroups based on how fast the antiepileptic drug was withdrawn. And in this case, the fast withdrawal was done in 24 hours, either before or after brivaracetam addition. And mostly, as I was mentioning, it was levetiracetam. This drug was withdrawn within 24 hours. And in the slow group, we've seen different modifications, and mostly the withdrawal was done, or the completion of the withdrawal was done up to 6 months, so quite a long period of time. So this was the difference. So in the first subgroups, we included only those patients who started brivaracetam and stopped previous drug within 24 hours, and mostly it was levetiracetam. And in the slower subgroup, the withdrawal process or the substitution with brivaracetam was ongoing for up to 6 months.
Thank you. And Torbjörn Thompson is curious about how seizure freedom was defined in the EP 104 study.
Seizure freedom definition was based on the EMA definition, so being, I'm wrong because it was 6 months, being seizure free for 6 months.
Okay. Thank you. And then a question from an anonymous attendee. Are there any post-marketing data for the efficacy of brivaracetam dosages above 200 milligrams per day?
I think there are only few patients in both studies available. So, and usually we exclude them because we build subgroups on the patients we recommend or how we recommend to be treated with brivaracetam based on our label. So therefore, those patients are usually excluded from the full from the modified full analysis set, so being on label set. And these are very single examples, and usually we don't include them into the effectiveness set.
Maybe a quick comment here. At the American Epilepsy Society in 2019, Professor Klein presented some data using a higher dose above 200 milligram. It was a small series, less than 20 patients, but I think the conclusion from that very small series was that there was no added benefit when using a higher dose. But of course, it's a very small sample. And I don't know if it has been published in a peer-reviewed journal, but I wanted to mention that for completeness.
Thank you very much. So the last question before we go to the next talk, we have a number of other questions that we'll come back to in the general discussion, but is raised by Professor Bialer. And after 4 years on the global market since approval of brivaracetam, what would you consider the major advantages of brivaracetam over levetiracetam?
I think I would delegate this question to Cedric, to you.
Thank you. I think I would say just two elements really quickly. So first of all is that we've seen in the randomized control studies, but also in real-world practice, that brivaracetam is also effective for patients who failed levetiracetam, including for efficacy reason, which suggests that it is indeed a different molecule. We also have interesting data showing that it really penetrates faster into the brain, which is less relevant in the chronic setting, but can be interesting in the acute setting.
Thank you very much. So Iryna, thank you for this presentation.